Good morning, everybody. We're going to talk about the moxifloxacin and the eye, pigment storms and transillumination. I am Dr. Muataz Hakeem, uveitis subspecialist in Baghdad Medical City. As we all know, the classic syndrome of Barry and Bate with bilateral acute depigmentation and bilateral iris transillumination are likely on the same spectrum, with the former describing acute onset of depigmentation of the iris without transillumination. This is the Bate, or the Badi, which is pupillary sphincter defects, and later entailing the presence of pupillary defect. It was first described in 2004 after pneumonia and prescribing moxifloxacin for it in Turkey, and the etiology is usually systemic antimicrobials, particularly moxifloxacin, but clarithromycin have been implicated. Interestingly, sensitivity to fluoroquinolone toxicity has been associated with HLA-B51 and HLA-B27, with 40 and 20% respectively, in a study suggesting an underlying autoimmune aspect. Antecedent viral infections have also been noted in about 2/3 of the patients. Symptoms of photophobia, ocular pain, red eyes often begin within 2 to 3 weeks of starting systemic antimicrobials, and visual acuity can be reduced but often recovers to baseline. Sorry, there is a technical issue here. The photo is not showing. Anyway, the examination shows depigmentation of the iris occurs at the iris root, while pigmentary cells are evident in the anterior chamber. Inflammatory cells are not. And there is a trick here to discriminate the inflammatory cells from the pigmentary cells by using the green light of the slit lamp. You know, the pigment will absorb the pigmented cells, while the white blood cells will reflect it. So when you change to the green filter, it will almost disappear, while the white blood cells persist. This is a clinical examination trick that can show you whether these are pigmentary versus white blood cells in the anterior chamber. Gonioscopy also reveals heavily pigmented pigmented trabecular meshwork, especially anteriorly, diffuse fine pigment on the corneal endothelium, but not KPs. In Bate, there is diffuse patchy bilateral iris transillumination defects with pupillary mydriasis and sphincter paralysis is often seen, but posterior synechia is found in a quarter to half of the patients only. IOP can be elevated in the first few weeks and may persist sometimes. Anterior segment OCT in Bate is useful, showing thinned iris with normal configuration, although segmental posterior bowing is occasionally noted. In Badi, the anterior segment OCT shows iris root damage and iris stromal thinning without affecting the pigmentary epithelium. Here we will start with case number 1, a 52-year-old female, non-case of increased intracranial pressure with peritoneal shunt, presented with regular age-related cataracts in her both eyes. So she underwent phacosurgery for her right eye. After 2 days of starting topical and systemic moxifloxacin, she was complaining from pain, redness in her left eye, the unoperated eye. And on examination, there was ciliary injection in her left eye, phakic lens, heavy AC reaction, +4 pigment cells, and pigmentation of the capsule, keratic and dusting of the posterior cornea, while the pseudophakic eye, the newly pseudophakic eye, had few white blood cells, which is regular for a regular phaco. After a few months of treatment with Diamox, anti-glaucoma, by glaucoma specialist, the decision was to follow up her on anti-glaucoma. She improved. Topical steroids, Diamox, anti-glaucoma. Prostaglandins were excluded from a treatment to hopefully to cause less irritation of the iris, and her IOP became controlled. She was kept on medical treatment, and heavy exercise was prohibited. Why did she have a unilateral iris transillumination. Studies say that moxifloxacin might have higher level into the phakic eyes due to slow turnover. The vitreous in the phakic eye had more. That's it.
Time is up.
Time's up. Sorry. I want to say here that there are many cases that I had which had unilateral iris transillumination, because in the phakic eye, the moxifloxacin level is higher, and the pseudophakic eye, the turnover is faster. So you may get a unilateral iris transillumination like the Bate or the Badi syndrome. Here's the message that I want to send. So always keep it in your mind. Thank you very much.
Thank you, Muataz. The judges, if they want to have a comment, or maybe the next one. Dr. Savadra, I'm Sangul.
One, that if you say that a pseudophakic eye has more turnover, how long does this last? Does it last forever, or is it related to the temporal relation to the surgery? So have you studied this? Who has studied this, and what was their
Actually,
basis
it's
of the
not a
science?
study, but I had
because
a
that is the basis of your hypothesis.
Yeah, I had a case series here of 6 cases. Unfortunately, we didn't have time to show them all. Of them, there are 3 of unilateral cases. All of them had the attack into the phakic eye after surgery. I think this is related to the higher vitreous level of moxifloxacin. The pseudophakic eye has a rapid turnover. Maybe the trabecular meshwork has been washed during the phaco surgery, so the turnover is enhanced over the first few weeks in the pseudophakic eye. That's why I had it in the phakic eye.
No, my question was, what you're saying is based on your thought, or somebody has really done a scientific study on the turnover of the antechamber
Yes,
or the trabecular meshwork? That's why I asked. So how long it lasts? Suppose somebody had cataract surgery today, will the difference from the phakic eye turnover remain for next 2 years, 6 weeks, 5 years? What does the literature say?
I didn't find a study except a single study that explains it pathophysiologically, actually. A single study, one only, that says that the turnover is slower. But they didn't mention the exact period of this enhanced turnover.
And that was a nice presentation.
Thank you.
And we had also a body case during the COVID period, but it was secondary to systemic moxifloxacin. But I couldn't catch if this patient also had moxifloxacin or not.
Yes. Yes.
For it's just as topical?
No. It was systemic. All of the cases, maybe 3 cases after phaco. One case had blepharoplasty, and the.
So do you give systemic antibiotics after phaco?
No,
routinely?
it's usually after like prolonged surgery or complicated surgery. For me, I don't prescribe it anymore since maybe 4 years. It was usual in our country that they prescribe moxifloxacin or ciprofloxacin, but I stopped it. Except in prolonged lengthy cases like trainees case or so. Yeah.
Okay, thank you.
Thank you very much.